We'll start with Jabbar, sir.
No problem.
Okay.
Since Kotwal sir is in the line, let him give a brief introduction
Yes.
also. That would be nice because his president is here. Okay.
Are we live now, Bashir?
Yes, sir, we are live.
Okay. Good evening, everybody. Greetings from Endocrine Society of India, and we welcome you to the virtual update on diabetes and Ramadan. Most of our patients face difficulty managing their glucose during these times because of the peculiar habits of eating in a particular time frame and not eating in rest of the day, and there is wide variation in the glucose control and because of lot of issues concerning low sugar and high sugar. So to discuss all this, we have curated a program specifically for how to manage your diabetes during the diabetes and Ramadan. We have an expert panel consisting of Professor P.K. Jabbar, sir was the past president of Endocrine Society of India and a avid researcher and excellent teacher. Welcome you, sir, for the program. We have Dr. Sheila Sheikh from Mumbai, who is a senior member of Endocrine Society of India and who has done multiple research on this aspect and written plenty of guidelines. Welcome, ma'am, for the show.
Thank you.
We
Thanks.
have Professor Narendra Kotwal, sir, who is the president of ESI, and Dr. Kaushik Pandit, who is the president-elect of the ESI. And I'm thankful to all of you for joining this session. And I thank Dr. Nalini for actually coordinating and conducting with all these people for the conduct of this program. So with this opening remark, I request Professor Naren Kotwal to just give an overview and then we hand over to the Dr. Nalini for conduct of the proceedings. Kotwal, sir.
Yeah. Thank you. Thank you, Dr. Hari, and good evening, everyone. On behalf of Endocrine Society of India, I welcome you all. Now, we are going to have a holy month of Ramadan, where our Muslim brothers and sisters would be observing fast. So, as a Endocrine Society of India, we thought we should have a program to apprise our healthcare professionals and as well as our patients also how to cope up with the various nuances which occur during fast. And I'm sure that today's deliberation will help all of us, not only healthcare professionals, but our patients also. And at the outset, I would like to wish everyone a happy Ramadan, and I hope that this Ramadan brings peace, prosperity, and spiritual enlightenment to all of us. Over to Dr. Hari.
Thank you, sir, for the encouraging remarks. Dr. Nalini, to please conduct the proceedings.
Thank you, Dr. Hari. At the outset, let me welcome you all to Endocrine Society of India virtual update on diabetes and Ramadan. Ramadan, as you know, is the 9th holy month of Islamic lunar calendar. And fasting during months is one of the 5 pillars of Ramadan, of the Islamic faith. So it involves complete abstinence from all food, water, medication, and every kind of nutrition that has to go in. And about 80% of the individuals living with diabetes, type 2 diabetes, fast during this month. And more than 40% people with type 1 diabetes fast during the holy month of Ramadan. So considering these numbers, it's prudent to guide the individuals in efficient management of diabetes through healthcare personnels. And it is the right time and moment to discuss such an important event when such an important event is about to occur. So to start our evening, let me welcome Professor Jabbar for his talk. He will be speaking on the myths and facts of Ramadan and the fasting. Jabbar sir. He is the professor and head of the Department of Endocrinology and is an excellent postgraduate teacher and investigator of several trials. And he has contributed to several textbooks and he has authored several papers, and he is the past president of Endocrine Society of India. Jabbar sir, welcome.
Shall I start? Shall I start, Nalini ma'am? Shall I start?
Yes, sir. Please start and
Yeah.
share your screen, sir.
Yeah. Screen is okay? You can see the slides, right?
So we can see, but you will have to change the
PowerPoint modes.
PowerPoint mode, sir.
Now it's okay.
Yeah,
Yes,
perfect.
sir.
Good evening, and now I send and brings regards from Kerala, God's own country, and special thanks to Endocrine Society of India and congratulations to Endocrine Society of India for arranging such a beautiful meeting, especially this topic, Ramadan and fasting, diabetes. See, my topic caption is little funny. Okay, facts and myths. During Ramadan, there are a lot of scientific informations there to observe Ramadan fasting. But in addition to that, there are a lot of myths also. And I've designed and I've selected few interesting areas where there are a lot of myths. So we'll look into that. Ramadan fasting, as Madam Nalini was discussing, most important pillar. There are 5 pillars in Islam. Number 1 is Shahada, that is strong belief. Number 2 is 5 times prayer. Number 3 is compulsory donation. Number 4 is fasting during Ramadan. Last one is Hajj, or it's a pilgrimage to Makkah. The fourth, the pillar, Ramadan's coming soon, within 1 week probably. And this aim of the presentation and symposium is to clarify certain myths surrounding to diabetes management during Ramadan fasting. There are a lot of myths, so probably Dr. Shaila, Dr. Nalini, Dr. Hari, Kaushik, all can contribute the number of myths, but I've selected few here. Now, number 1 issue, people think that physical activity should be avoided. In fact, it is not necessary. And see, what I learned from Islam, being a Muslim doctor, see, you should not change the lifestyle totally. See, you can go for little modification of your lifestyle. That is most important for you. And in fact, you can go for light and moderate physical activity. Definitely that will be beneficial for your well-being, not only for your well-being, for maintain your glucose and other metabolic milieu, definitely is useful. And please remember that vigorous exercise, especially we are expecting the significant rise in temperature during Ramadan this time. So definitely moderate physical activity, that's okay. And there is interesting prayer. We used to pray in the form of namas 5 times. And after around 8 p.m., there is an important special prayer. Namas, you can call it as Taravi prayer. We have lot of time we are spending with the movements of your joints. And mentally you are concentrating into God, and your physical activity is vigorous. In fact, that will last around 30 to 45 minutes. That's really useful for useful type of exercise for our patient with diabetes. And very importantly, those who are having high risk for developing hypoglycemia and taking high dose of insulin or secretagogue you should not go for excess physical activity. And I want to add one more point here. Whether to observe this type of patients is also very important. You can go through the documents published by IDF, and they have included Fatwa Islamic opinion also from scholars. So all these things are important. You can look into that. So exercise part we have decided you can go for exercise. There is no issue. Now what is happening during Ramadan, especially in Middle East, I was in Middle East for a long time. The people are not doing exercise. They're taking a high calorie and they're taking rest in the bed. That is not good for our health. I think that is not the advice of Prophet Muhammad also. Now, number 2, all individuals with diabetes mellitus should not fast during Ramadan. But in see, there are certain criteria, certain guidelines again by IDF, and there are fatwa from Islamic country also. In general, fasting is not contraindicated for all patients. And there are risk stratification. I will tell you very simple. You need not look into all those things. This chart is available in ADA recommendation 2025, gives a very comprehensive scientific opinion, whether you go for Ramadan fasting or not. So this scoring system is good. With this scoring, you can go for stratification. Is it a low risk or high risk? High risk, my opinion, it seems Islamic opinion also don't go for Ramadan fasting, especially those who are taking lot of insulin, multiple episodes of hyper, and complicated target organ issues. Those situations better don't go for Ramadan fasting. As a Muslim doctor, I can tell you one more thing. See, God is always with you. He doesn't want to trouble people. There is no doubt about that. So Islam gives a lot of freedom to choose. But you can follow all these scientific recommendation whereby you can advise a patient to observe Ramadan fasting or not to observe Ramadan fasting. See, very important, hypoglycemic symptoms you should explain to the patient. Hyperglycemic symptom you should explain to the patient. But very one piece of information I want to give. After breaking Ramadan fasting, after your namaz or maghrib namaz, what you can do now, don't go for lot of carbohydrate or containing carbohydrate or fat containing that will reduce your efficiency of work, and probably that will produce little sleepiness. So you will lose your time for your subsequent prayers and all. Now, coming to yet another myth, that is consuming large amount of food, which already is mentioned now, and that will stabilize a glucose level. And in fact, I'm from a village. I know people are thinking that immediately after taking or after Ramadan, breaking Ramadan fasting, you should take lot of carbohydrate. My dear friends, don't do that. Overeating can produce lot of problems. Hyperglycemia can occur, and subsequently you can go for hypoglycemia also. Hyper, something like that. So because of this danger, the advice is it is advisable to go for small, light meal and followed by a balance. See, this is the recommendation. Please remember, avoid foods rich in sugar. We are taking lot of juice which contains sugar. That should not be there. And refined carbohydrate, like all these things are happening in my place at least. And starchy food should be limited, but if you modify the carbohydrate to complex carbohydrate, that will be useful. So the message is, take small food, don't go for heavy food. And weight loss, the people think that, see, if I'm fasting for Ramadan, you will lose weight. Nothing, my dear friends, nothing will happen. In fact, Epidiar data, all data showed weight changes are very, very little. And in fact, some patients are gaining weight also. You know why? Because Ramadan time, you are getting a lot of invitation from various association, residents association. You are going there taking a lot of high carbohydrate and fat diet. So that won't help you. So these are the few recommendations. I'm sure that Dr. Shaila is going to discuss all those things. And another point, which is a myth, it's happening in Kerala state at least. People think that you should not use fruits. No, you can take fruits, but don't put extra sugar into that. That will produce hyperglycemia. Raw few fruits without making juice is not bad. You can use it, and fruit can be included in the diabetes friendly diet when you are selecting the footsteps wisely. That's very important. And these are the certain recommendation, how to calculate, how to modify your diet. what is shown in the lower panel, you go for multiple small pits that will be useful. And sugary drinks, say, please, for heaven's sake, don't go for this aerated water, juice. All these things can produce a lot of small metabolic issues, and eventually that will be a real problem for maintaining your euglycemic level, even with the good treatment. There are certain principles of Ramadan nutrition planning which you can follow. All these simple advices are available in the net also. And what I want to tell you that go for small food during iftar time, and you can delay the sahur as late as possible, probably somewhere around 4 a.m. or 4:30 a.m. And see, healthy food you should take, like that contains little carb plus carbohydrate, especially at this time of suhoor, will be useful for preventing hypoglycemic episodes. And medication, Dr. Shaila is going to discuss about that. You should get proper advice from your doctor, and you can do it. And people with the diabetes should not take their medication. Don't do that, especially if you are taking insulin. There are people that are type 1 patients also. They are not taking insulin. If you are not taking, that will be dangerous and detrimental. So we should not do that. Please go to your doctor and go to get a proper advice for adjusting the dose of insulin. Insulin treatment, I'm not discussing in detail. SMBG, will it produce the breaking of Ramadan? That's a very important myth. If you are going for capillary blood sugar assessment, definitely there is no harm for Ramadan fasting. Please remember that. Don't skip your suhoor for reducing the blood sugar, because if you are taking drugs, especially secretagogue and insulin, you are likely to develop hypoglycemic episodes. So there are various myths is centered around Ramadan fasting. See, these are the certain simple dietary pattern also for managing diabetes during Ramadan time. My dear friends, there are n number of myths with Ramadan fasting. Please, Islamic system is very simple. You can ensure better health profile with adjusting your diet and medication with the concurrence of your physician also. Balance the risk, very important. If the patient is taking multiple doses of insulin, probably Ramadan fasting is not Faral, you can stop it and you can do whatever the compulsory sadaqah or donation for that purpose. And individualized care and proper monitoring is also essential. I always consult healthcare professionals and those who are having experience in managing diabetes during Ramadan. Please take the opinion, and you'll get a very positive impact and positive effect. May Allah give barakat for you for during the Ramadan time. Okay, I'm stopping it. Thank you very much for the kind attention, and I'm waiting for the questions also. Thank you very much once again. As-salama.
Thank you so much, sir, for such important session. The take-home messages are very crisp and clear. Light to moderate activity is okay. Small meals, no juices. Follow Ramadan nutritional plan. Not much weight changes are there, so don't look into the weight. Capillary blood glucose, when you check it during the fast time, is all right. It doesn't cause breaking of the fast. And go to your doctor, consult the medical professional who is experienced in treating diabetes during Ramadan. Thank you so much, sir, for such an important session and breaking the myths of our friends and colleagues. Moving on to the next session, which is an equally important session, diabetes and Ramadan, change in diabetes medication and monitoring. How do we change the medications? The session will be spoken by Dr. Sheila Sheikh. Dr. Sheila Sheikh is a senior consultant endocrinologist at Saifi and Reliance Hospital, Mumbai. At the outset, congratulations, Dr. Sheila, for receiving the Hamdan bin Rashid Al Maktoum Foundation Award. She's done a research in Ramadan scoring system. So congratulations for that. And she's an expert in diabetes in Ramadan. Over to Dr. Sheila Sheikh for the topic.
Thanks, Nalini. At the onset, definitely I would like to thank ESI for giving me this opportunity, and a big shout out to Nalini for all her patience with me during the last few days. we've been overburdened with work related to readjusting medications for our patients during Ramadan. And I know I've not been the best of speakers to connect with Lakshmi because she's been really chasing me. Thanks for that, Lakshmi, and apologies for that. Dr. Jabbar has actually, laid the ground and made it very, very easy for me. He spoke about some very, very pertinent issues that rise during Ramadan, especially what is related to the feasting part of Ramadan. We all are aware about the fasting part, but often what we do not realize is there's a very important component of feasting out there, which does cause a lot of fluctuation as far as your glucose management goes during Ramadan. And when you actually look at the key risks which are associated with Ramadan fasting, you would realize it is not only hypoglycemia. We all pay a lot of attention to hypoglycemia, of course, and that is the right way because of the inherent risks associated with hypoglycemia, and especially in countries where the fast can last up to 20 hours in the summer month. This year, the fast, which is going to start from next Sunday, is going to last for around 14 hours. Along with that, but a very, very important component is also hyperglycemia. That is the post-iftar hyperglycemia. A lot of myths, a lot of important myths which have been just busted by Dr. Jabbar, which are going to be really very helpful in managing your patients. Actually, when we start looking after our patients, it's very, very important, friends, which you would realize as we show you some slides along the way, is that the education starts much more earlier. And I wouldn't say the education actually starts much more earlier, but it's a reiteration throughout the year because you cannot really change a person's behavior pattern just before Ramadan, except for, of course, the feasting and the fasting part. By behavior patterns, I mean the monitoring part. By behavior patterns, I mean the lifestyle part. Because somebody who's not done it for the previous 11 months is not going to suddenly make major changes in their lifestyle as far as all these other patterns are concerned. So my request always to everybody is that when you are looking after a patient who is going to fast in the next Ramadan, it is something which the patient, it should be sort of that conversation with the patient regarding fasting should be much before, definitely 3 months prior to the onset of fasting. And if possible, at every consultation, there should be some kind of, conversation pertaining to Ramadan. Because what I have realized is that when patients want to fast during Ramadan, they're a little more health conscious. If we tell them, see, you need to be in a better zone so that you can fast during Ramadan, that works as a very, very important positive motivating factor in our patients. Not only do the eating patterns change, as we all know, very, very important parameter which changes is just sleeping patterns. And when I talk about sleeping patterns, sleeping does become fragmented. Though we all continue with our routine activities throughout the day, the fact remains that sleeping, because there's more time spent in prayer, that sleeping pattern can get very fragmented with maybe 4 to 5 hours of sleep in the night, maybe some amount of sleep in the day, but definitely decreased total sleep time, delayed sleep, decreased REM sleep duration, and all this is finally going to contribute to all the hormonal changes which occur during Ramadan. This is a classical picture of how patients used to behave. This is 2015 data. The only reason I put up this slide for this meeting was because this is how we saw them behaving all these years. This is how we expected them to behave. You would be surprised now with medicines which do not have that much of a hypoglycemic potential, and with a significant amount of education regarding diet and exercise. This typical curve which you see has become flattened to a significant degree. We are able to more or less with proper education, proper monitoring, make it reasonably, I wouldn't say absolutely similar, because all said and done, there is going to be some amount of dietary indiscretion at iftar, to be very honest with you. And we all are equally guilty about it because there's ad libitum availability of high calorie food. And as Dr. Jabbar said, iftar parties are, something which you simply just cannot totally not want to go, frankly, to be honest with you. So these kind of graphs, but definitely you see on fewer days of the month as far as the patient is concerned. And that is maybe because now we are able to stratify our patients much better. We all know about the risk stratification tool, and we all know that we have used different parameters which could potentially influence our patients' risk during fasting and given it a scoring system. The main thought process behind giving it a scoring system was that we can individualize risk. The scoring system, the risk stratification tool, which was there prior to this tool, did give us broad guidelines as to who can fast and who cannot fast. But what was realized when we saw those guidelines that was that if we typically stuck to those guidelines, for example, what happened was maybe a patient who is geriatric but is otherwise very healthy was told not to fast simply because they did not fit into that criteria. And maybe somebody who was younger who was told to fast but was actually not fit to fast at all. And that's when we realized that, and the worrying part was that when we tell somebody not to fast, the onus is as much on you as a clinician as much as it is on the patient. And these guidelines, as Dr. Jabbar rightly said, are endorsed by the religious authorities. So the religious authorities are also saying that if you have decided that this patient has a high score and medically you're advising the patient not to fast, then that is absolutely accepted under the religious guidelines. And that, friends, actually lays a huge burden. It's a phenomenal burden because you're like, okay, I am along with the patient. And I always say along with the patient because other than what these risk posted, there are a number of other factors which influence decisions. It could be the patient support system. It could be what kind of food is available. It could be how is the patient going to be managing the food. There are so many aspects to a person fasting other than actually also what we have given the guidelines, which is impossible for us to cover every aspect. And that's the reason why we've said that individualized therapy. But if you have told a patient who's at high risk and they're not supposed to fast, then we need to be sure that, yes, these are the reasons why we are asking you, requesting you not to fast because it is not safe for you. At this point of time, I can very happily say that patients actually accept what we are saying for the simple reason that they believe that we are on the same table as them and we want them to fast. Our conversations always start with, we want you to fast. We are going to try our best to make it as safe as possible as we possibly can. But in case we feel the risk is too high for you, we know that Allah means no harm for you and we are going to request you not to fast. 99% of my patients will agree. 1%, of course, as we all know, will still say, ma'am, I still want to try. And then we try to the best of our ability to help them fast in the safest way possible. And how do you really do that? How do you actually, absolutely in a scientific way, stratify that? You have all this on a chart. You would mark everything on the chart to be sure that you've not missed anything in a very busy OPD. And that can happen. We all are humans, and in a very busy OPD, it's very easy not to see something and and think that you've said everything. First important thing, definitely risk stratification. You need to stratify where your patient is, which I just spoke about. Second very important thing, friends, and the reason I say second very important thing is, of course, you have your fluids and dietary advice, which I won't talk about much because Dr. Jabbar has already covered it. The exercise advice also is spoken about. I'm going to basically mainly talk about the medication adjustments and glucose monitoring today. Now, once you assess the patient, you've gone through all these factors, how would you make an individualized plan? Definitely a detailed medical history, what comorbidities you are going to be looking at, what is the patient's prior experience in managing diabetes during Ramadan, a very, very important factor. How is the individual going to actually self-manage diabetes? And in this, a very important fact, which Dr. Jabbar already has reiterated to, is when should the patient break their fast? We have faced situations where the patients will actually feel that maybe I'm not feeling well because I'm fasting, and just go to sleep. Just go to sleep, and it's only before breaking the fast, when somebody goes and wakes them up, they realize the sugar is really very low. It often happens that patients do not take into account minor symptoms. If they're feeling a little giddy, they're feeling palpitations, it's always put down to fasting. So it requires a lot of education and an entire family to be educated to explain that, see, you need to break your fast because fasting does not mean harm to the body. And it is a lot of education and re-education. Believe me, even patients whom we have explained that, no, you can trick yourself, it will not negate your fast. Every Ramadan, I will have the same patient again asking me, Madam, are you sure? I mean, I'm asked this, are you sure? That skeptical looks so often. And then I have to quote every name I know that, yes, so-and-so person said this. Yes, this is where we are quoting from, for the person in front to be relaxed enough to say, okay, I am going to prick myself so many times. We have a similar problem with CGMS. We are doing a lot of CGMS, especially in our elderly patients. And there's a lot of, again, hue and cry about whether it is allowed, it is not allowed, are we allowed to do it? Till now, we again have a guideline which says, yes, CGMS can be done in your patients who are fasting during Ramadan. So this kind of education, this kind of reiteration is very, very important. Now, when you look at the 7-point guide for Ramadan, friends, this guide does not say that every patient has to do all these 7-point sugars. No, you don't have to do. For example, if a patient is only on metformin, I am not going to ask my patient to do all these sugars at 7 point. He's never done it before. I will say that in case you have any symptom of hypoglycemia, which again, as I said, though this metformin is known not to be an anti-hyperglycemic drug, if you're not feeling well, please check your sugars. These patients, if they're checking their sugars prior to Ramadan, they would continue checking their sugars maybe once or twice in the week. But this 7-point guide for Ramadan is on patients who are much more higher doses of medicines, who may be on medicines which potentially have hypoglycemic efficacy. We use a lot of SUs in our country, a lot of our patients of insulin, and in some patients who have this increased risk of hypoglycemia, and even patients who sometimes may not be aware about hypoglycemia. So in these patients, definitely I would request them to definitely check their sugars at suhoor when they get up. Again, when they get up in the morning, a number of our patients would most probably get up at 11, 12, because by the time they sleep after saying their morning prayers, it would almost be 6 to 6:30. So if they have the luxury of sleeping, they would sleep till 12. We ask them to check their sugars again at 12. At the time of iftar or evening, if my patient says, ma'am, I'm going to check my sugar only once or twice, I'm not going to check my sugars otherwise, I will tell them very categorically, please check your sugars pre-iftar. It's very important that I understand that they're going into hypoglycemia. And please, if possible, also check your sugars 2 hours after the iftar or after dinner. Again, this varies from place to place, from city to city. For example, in Mumbai, a number of patients break their fast maybe in their workplace. For example, I break my fast in the hospital, which can be just a date and water. And then you most probably have a meal maybe sometime down the line. Now, a lot of patients who are doing that, then checking their sugars 2 hours post iftar does not make a lot of sense. It would make more sense to check their sugars 2 hours post dinner. So a lot of individualization as to where you would check sugars, a lot of individualization as to where exactly could potentially be the problem area. You know your patient, you know your patient's lifestyle, you know your patient. Your patients will tell you. I have some of my patients, when we give them dietary advice, actually tell me, ma'am, please jaane do. 1 month, please let it be. 1 month, I'm not going to do a thing on her. I will again do after Ramadan. And at the other end of the spectrum, I have patients who will be absolutely disciplined and tell me, ma'am, we'll do exactly like this. I'm going to see to it that my diabetes does not go out of control. Don't worry. So you have both ends of the spectrum. The way you have both ends of the spectrum, monitoring also is individualized, friends. Ideally, 7-point guide, for example, in your type 1 diabetic patients, 7-point guide in your patients with early CKD planning to fast, 7-point guide in your patients with cardiovascular disease, frail patients, elderly patients, any of these patients, pregnant patients, we strictly request them not to fast. Any of these patients is where you would tell them, okay, this is the kind of monitoring I need. And you need to request them if you are unable to do the monitoring. I cannot honestly reach a conclusion about the safety that you have as far as fasting is concerned. Your risk increases significantly. And if we need to reduce this risk, we need to put you in a category where it is comfortable for you to fast. I need you to monitor yourself. But does this happen? Honestly, does this happen in the real world? The CAP and the practice of diabetes self-management during Ramadan fasting, these were Malaysian patients. 35% did not ever perform an SMBG. And what was interesting is that slightly more than 0.5% of the participants practiced SMBG throughout the month of Ramadan, but most of them did it only once a week. So patients do not follow our guidelines at this point of time. Closer home, this was data which was presented by us. We were surprised that 33% of my patients, this is my clinic data, including data across India, Bangladesh, and Pakistan, 2021. Very, very interesting data. What was very interesting, friends, was it was a common reflection across Southeast Asia. a number of our patients did not have glucometer. And it was actually very, very disheartening to think that we are educating our patients from weeks. And then when we saw this data, what we realized is that when I ask a patient, are you monitoring? My patient very, very vigorously nods their head. Yes, I am monitoring myself, ma'am. And when they go outside and you ask them, do you have a glucometer? They say, no, I don't have a glucometer, ma'am. Said, monitor. I monitor when I go to the lab. So there is so much of, differences as far as language is concerned. 43% friends, even as later as as recent as 2021, believe finger pricking would actually break their fast. 58% did not regularly monitor. 38% do check their glucose levels, and 27.7% do not check, though they have a glucometer. They say, we don't want to know. We're not interested in knowing, because if we know, we are going to be in trouble. What did the 2020 global survey DAR tell you? Here, the percentage of people who performed SMBG definitely was better, 73.8%. But a very
Apologies, Shalama, time check, please.
Sorry?
Time check, please.
Yeah. Majority of participants who performed SMBG at the same frequency as before Ramadan. So yes, this is what was seen during Ramadan. Fluids and dietary advice has already been given by Dr. Jabbar. I'm not going to talk about that at all. What I'm going to spend the last 2 minutes in talking about medication adjustments. And again, why are we talking about medication adjustment? Because what Ramadan focused education shows that there is a definite reduction in HbA1c levels. Most of us would be doing this very, very simply. Acarbose, metformin, thiazolidinediones, DPP-4 inhibitors, GLP-1 receptor agonists, no dose modification is required. Sweet, simple. But if the patient has metformin, for example, twice a day, you would shift it to once a day. If the patient is on thrice a day, again, you would shift it to a twice a day dose. The hitch comes with sulfonylureas because those are the drugs which cause hypoglycemia. And these drugs, among these two drugs, there was a significant amount of data with gliclazide, which shows a very, very reduced risk of hypoglycemia. So, and especially if the gliclazide modified release is taken in the evening, just after you break your fast with maybe a date. SGLT2 inhibitors, no dose modification is required, but timing is changed. Emphasis on hydration, emphasis on hygiene, and emphasis definitely on the fact that if any kind, and emphasis also the patient on diuretics, monitoring as far as blood pressure is concerned. What about insulins? Once daily, reduce the dose by 15 to 30%, take at iftar, relatively simple. Twice daily long acting, you would again take the usual dose at iftar, but you basically just make a switch as far as insulin is concerned, friends. The evening dose goes in the morning and the morning dose comes in the evening. When the morning dose comes in the evening, it is the same. But when you switch the evening dose to morning, since the patient is going to be fasting, you reduce that dose by 20 to 50%. It actually works quite comfortably along with monitoring your patients. At this point of time, co-formulations are what we increasingly use during Ramadan, because though as far as HbA1c was concerned, pretty well matched, the issue was mainly, friends, as far as hypoglycemia was concerned, which was much better, much more reduced in patients who were on co-formulations vis-a-vis pre-mixed insulins. We've been looking after populations who are on oral semaglutide, which we all know has to be in the fasting condition, and we take it first in the morning. During Ramadan, what we are doing is either you take it when you break the fast at Maghrib and then you have your meal half an hour later, or the other option is you take it in the morning before suhoor, because what is very, very important for you to also remember is the patient has to wait for 30 minutes before consuming any kind of meal. So the pre-suhoor period has to be more than 6 hours. You cannot take it with more than 120 ml of water. We do not know what effect when one day it has, and post-dose wasting waiting time of 30 minutes. Follow-up, very important. Again, a lot of problems can crop up over here if the patient does not follow up. And hence, education is what makes a very big difference, be it our HCPs, be it our people living with diabetes, be it our general public. That is the best way forward. Thank you very, very much. And I am going to close it over here. Thanks, friends, for listening to me.
Thank you so much, Shaila ma'am. That was a very essential topic that we have discussed today. To give your points, and Chris, it's very important to understand the eating pattern, to understand the sleeping pattern which changes understand and stratify the risk of the patient, because it's very important to tell which patient can fast and cannot fast. The onus is on us also when we tell them be proactive, do it as early as 3 months, and be on the side of the patient and along with the patient when they do this. New generation sulfonylureas, SGLT2 dose reduction is not there, but do increase fluid intake during the non-fasting times, and insulin dose adjustment for twice a day insulin, just reverse and reduce the dose by 20%. These are the take-home messages, crisp and clear message, which is very important for our patients to follow. Uh, Over to Naseem for the very important and interesting panel discussion that awaits us. Dr. Naseem, please.
Good evening, all. I'd like to thank ESI for giving me this opportunity. Today, we are very lucky to have four highly experienced and eminent endocrinologists as our panelists. Joining Dr. Jabbar sir and Dr. Shaila madam will be Dr. Narendra Kotwal sir and Dr. Kaushik Pandit sir. Narendra Kotwal sir, as we know, is the current president of Endocrine Society of India, is also the director of endocrinology at Paras Hospital, Panchkula. Kaushik Pandit sir is the president-elect of Endocrine Society of India. Sir is also the chief endocrinologist at Bellevue Clinic, Kolkata, and research scientist in IPGMIA. Because of some technical reason, Kotwal sir may not be able to join the session right now. Sir has asked us to continue with the session. Today's panel discussion will be about Ramadan and diabetes from the treating physician's perspective. There will be discussion points or queries which we usually come across during practice. Few of this has been taken care in the last two sessions, but I'll go through those. Like the first query was how to approach towards GDM patients who are strongly insisting on fasting. If Dr. P.K. Jabbar sir can guide us through this.
Sir, kindly unmute yourself.
Okay, Dr. Nasimuddin, good question. Say Islamic belief is very strong, Any patient, even very old babas, okay, they don't want to quit Ramadan fasting. So in diabetes and pregnancy or GDM, probably GDM is very light. For GDM patients, we should categorize a patient to different levels. Suppose you have a patient, GDM, only dietary modification, there is no issue. If patient is taking one injection, there is no issue. But see, it is not compulsory. Please remember that. Islam is always having a soft approach. Islamically speaking, if mother is very much worried about the health of fetus, okay, she can abstain from Ramadan fasting. There is no issue. If they're taking insulin, multiple doses of insulin, I would recommend don't observe Ramadan fasting during pregnancy time. If they're taking multiple doses of insulin, 3 doses of regular insulin, 1 dose of long-acting or longest-acting, whatever type of insulin, only non-pharmacotherapy, there is no issue. Yet another scientific phenomenon, the ketones, that's also a worry for a GDM and pregnancy. The ketone production in non-insulin taking, or you can call it as mild diabetes mellitus, there is no much detrimental effect on the brain development of fetus. So there is no worry, but if they're taking multiple doses of insulin, better don't go for fasting. Okay, Islam is permitting for all those things. Okay, go ahead, Nasimuddin.
Thank you, sir. Thank you, sir. Thank you for the guidance. The next query is, we know that type 1 diabetes comes in the high-risk criteria, but in case these patients are insisting on fasting, could there be any best insulin regimen for them? Dr. Shaila madam, if she can guide us through this.
Dr. Naseem, for type 1 diabetic patients at this point of time, if there's new data which says if the patient is, for example, on the insulin pump, these patients can fast quite safely. So in type 1 diabetic patients, there's a decent guideline which has come out around 6 months back, which is specifically for type 1 diabetic patients who are on the pump. So the insulin pump makes things very easy and safe for them to fast during Ramadan. So that is one part of the story. Other type 1 diabetic patients, if type 1 diabetic patients are uncontrolled, have no kind of family support, are not willing to monitor themselves, are not willing to follow dietary compliance, strictly big no as far as fasting is concerned. Type 1 diabetic patients with newer insulins, we have our newer insulins because you have an ultra long acting insulin, you have your ultra short acting insulin. With close monitoring, may be allowed to fast initially, very, very close observation. And if under observation you see no, when I say observation, I mean monitoring on the entire gamut of monitoring. And if in that you find no issues, they may continue fasting under close observation. But it is definitely as a risk factor, a high risk factor as far as type 1 diabetes goes. And in certain situations, if the patient is insisting with all these caveats, you can help them fast. But in patient who is not controlled, not willing to go the whole way, it is a big no.
Thank you, ma'am. Thank you for the insight. Next query is there any role of CGM in Ramzan? And if we are planning to do it, is there any best time to do it? If Dr. Kaushik Pandit sir can give us advice.
Thank you for the question. We know that compared to the pre-Ramadan and on the other days, during Ramadan, there is a drastic change in the lifestyle. There is sleep deprivation, there is a change in the exercise pattern, but most importantly, there is a change in the feeding pattern as well. And this feeding pattern, if you look into this one, in contrast to in the non-Ramadan days, where there is usually a standard 4 meals a day in a 24-hour span, there is actually 3 meals which is clumped together in a very short span of 12 hours. So the ingress of carbohydrate inside the body and also lipids and others, there is a drastic change. In addition, there is also changes that have been measured, that there is a increased gluconeogenesis, increased glycogenolysis, there is increase in the insulin resistance, there is increase in the glucagon, and all this comes into play in changing the internal milieu of a person who is undergoing the Ramadan fasting. Obviously, that changes the internal milieu in the sense that there is a change in the glycemic excursions or glycemic variability. And to measure this one, probably a very important tool is a CGM. And therefore, it makes sense to measure the glycemic excursion and the variability in a person who is at least prone to develop problems because of this. This might be important to do a pre-Ramadan time CGM and follow it during the Ramadan time to see how much of the changes that is happening, how much of the changes is causing a problem in the person who is undergoing Ramadan or observing Ramadan. And therefore, it makes it easier for the treating physician to take a decision whether to continue the Ramadan fasting or whether to make associated changes in the dietary pattern, associated changes in the exercise pattern, associated changes, very important, in the medication pattern. So CGM in such situation may be very helpful.
Thank you, sir. Thank you for the advice. The next query is, some patients will come to us like asking which is the best time to do exercise during Ramzan. And if they're planning to do Taraweeh the whole month, is that enough? If PK Jabbar sir can guide us through this question.
No, exercise is one of the important aspect of diabetes management. And any type of exercise you can do, there is no issue. But of course, vigorous exercise is not good. There also we should divide the patient category. Only non-pharmacotherapy or beta cell sparing treatment, beta cell involved treatment, insulin. So first group, there is no issue. Second group, there is no issue. Any exercise you can do. Regarding the timing, see, after somewhere around 3 p.m. or 4 p.m., these patients can have extra fatigue, possible even though they can manage. Those time probably is not good. After iftar, good. That will reduce the postprandial hike also. And anytime there is no issue. But Taraweeh prayer is really good. That it involve the contraction of multiple muscles. But probably that is not sufficient to burn out a lot of calorie. And what I feel, Taraweeh is good. You can go for exercise of mild to moderate intensity exercise. That's simple walking, little jogging, swimming. All these type of exercise is acceptable. At any time you can do that. But vigorous exercise, don't go for that. Multiple dose of insulin, especially afternoon time, is not good. That's my answer for the time being.
Thank you, sir. Thank you for the insight. Next question was taken actually by madam. How to manage a patient who has been using oral semaglutide during Ramadan for Shaila madam.
Dr. Naseem, oral semaglutide, the basic issue is only the absorption and the fact that there has to be, you don't have to eat anything for the prior 6 hours and for the next half an hour. So generally, the problem arises with if and during Ramadan is people also consume meals very late. Average if the say suhoor time is going to be around say 4:30 this year. Now the person has to not eat anything for 6 hours prior to that. And most of us in Ramadan, however much I may say, don't have high calorie foods. Most of us will eat something by 12 o'clock. Honestly. Honestly. I mean, if you ever come to Mumbai, Naseem, I mean, our streets are full of food all night. So that becomes actually very difficult for patients, not to eat anything for 6 hours prior. So the guidelines say you can do it either way. An easier way is to maybe then ask them to have it at iftar with just 120 ml of water. Again, a little problem over there that we've been facing is patients are unable to wait for half an hour. And as we all know, iftar is a social. It's not only us. I mean, Ramadan is not only spiritual, Naseem. It's also a social occasion. Like families will come together, people eat, break their fast together, pray together. So it's a lot of people who connect. Now, suddenly, if somebody says, I'm not going to eat now and I'm going to eat after half an hour, it leads to a lot of questions, a lot of questions, a lot of queries. So we individualize it. Whatever the patient and the family is more comfortable with, we try to do that. But the principles remain same. You need to not eat or drink anything for half an hour after your meal and have your tablet with less than 120 ml of water.
Thank you, ma'am. Thank you for the insight. Next question is for Kaushik Pandit, sir. When to do the post-Ramzan follow-up and any specific parameters that we should ask the patient to come with?
Well, after the Eid celebration for 3 days is over, and patient come back to the usual standard lifestyle, as was in the pre-Ramadan days, we also have to appreciate the fact that during this 1 month of Ramadan, there might have been some metabolic changes which has undergone in a particular patient. All what is important, what Dr. Jabbar and Dr. Shaila had stressed on, is that it's not one size fits all strategy. We all have to appreciate that there is a risk stratification procedure, and we categorize patient based on that. People who are at very high risk, we do not advise them to go for safe Ramadan fasting. Otherwise, they can certainly go for that one. So people who, based on this risk stratification, will have to think that our strategy to reconvene them into the older methodological status of the medication and the lifestyle should be reinstituted. And whether this Ramadan has caused any changes inside the body, we need to recheck within 1 to 3 weeks after the Ramadan. So it makes sense for them to come back to their treating physician and take stock of the situation. And there, he or she has to undergo some tests, depending on the risk profile. As I've said, people who are having a significant degree of kidney disease or heart disease would have to undergo many parameters. But at least in all people, we will have to see the glycemic parameters like fasting and PP sugar, as well as the glycated hemoglobin. If the glycated hemoglobin is either high or low, you devise your strategy about changing the medication to the needed way. In addition, in some people also may need to go for ketone testing or CRP testing or ECG or creatinine or sodium and potassium, and some people may also need to go for the echocardiographic testing depending on the situation. So there's no cut and dried answer to this question, what the test that needs to be done. The tests need to be individualized based on the background of the patient and how intensively Ramadan fasting has been done. So I'd go back
Thank
to
you, sir.
Dr. Nasim.
Thank you, sir. Thank you for the advice. The last set of questions are for PK Jabbar, sir. Like, is there any difference between intermittent fasting and Ramzan fasting? And some patients who are looking for weight loss, could it be beneficial for them?
The intermittent and religious fasting is different. All right. Intermittency is some sort of voluntary. The other one is, for a set of population is compulsory. But regarding your last part of question, weight loss and weight gain, in fact, Dr. Shaila was discussing beautifully. During Ramadan, none of the patient will reduce weight. Okay, because these type, like say gathering, social or Islamic, whatever type of gathering, we will take lot of calorie. This is not for one day by Saab. This is for 20 or 30 days. When I was in Dubai, there is a special dish, you can call it as arisa. Arisa, 200 ml of arisa contains around 1,200 kilocalorie. Because mutton, ghee, kismis, cashew, and number of high or packed calorie food they are taking. And after that also you go to Malabar, okay, in Kerala state, they are all taking very heavy calorie food. So weight loss is almost impossible. It's not for weight loss alone, my friend. This is for multiple benefit which is happening. For me, I can tell you one thing, my tummy will comes down, okay, at least for 3 to 4 centimeters. That is one of the merit. Personally, I witnessed it. So regarding weight loss, even the EPIDIAD data or whatever scientific documents available, very clearly written, weight loss is not as significant. But you can, if you reduce your food, if you manage your food properly, if you observe your exercise, definitely you can reduce. Intermittent fasting, there also people are observing this fasting is not for Muslims alone. Even our predecessors, all caste, including Hindus, Christian, they're all observing fasting. That won't reduce the weight. Okay. Anyway, it's time to stop it. And Nazimuddin, I'm handing over the mic to you. Okay. Lakshmi is giving.
Thank you, sir.
Message. Okay.
Thank you, sir. Thank you for the advice, sir. With this, we conclude the panel discussion. I'd like to thank all the elite panelists for sharing their knowledge and experience with us. It will definitely be helpful in treating the patients. Next session is going to be the release of the patient information leaflet. For that, we would like to invite all the respected panelists to unveil the patient information leaflet.
How do you do that?
The tech team will help you, sir.
Tech team will help.
Yeah.
This leaflet is going to be available on ESI website under the patient section in diabetes subsection. Thank you, respected doctors. This is going to help a huge number of patients who are planning to fast in this holy month of Ramadan. Now I would like to hand over to Dr. Lakshmi Nalin Madam to convey vote of thanks.
Before concluding, say a small word of appreciation. I wanted to convey my greetings and congratulations to entire team of Endocrine Society of India, starting from our Kotwal sir, and special thanks to Lakshmi ma'am and Shaila Sheikh for arranging this type of beautiful academic, very useful Ramadan fasting session. Thank you very much. I'm closing.
One point for me is that I would like to congratulate the whole ESI team, not only that, but special thank goes to Dr. Sheila and Dr. Nalini for formulating this patient handout, which I'm sure would be very helpful in for our patients to look into and follow the fast as per the guidelines. Thank you.
all credit to Lakshmi, sir.
Only thing we request everybody, we will put it in the official group. We request you can share it with all your patients who are keen for fasting. That becomes a handy from the society. I'll put it in the official group as well. Thanks to Shaila ma'am and Nalini for taking pain to create this. Nalini,
Thank you so much, sir. At the outset, let me congratulate Naseem for such a spectacular, very good discussion. Dr. Naseem is an endocrinologist from Hyderabad, and he is Dr. Kaushik's student, I would say, passing out from IPG Bar. Thank you, everyone. Thank you, ESI. Thank you, speakers. Thank you, dignitaries. And thank you, all the participants, for being here. It's very important to understand the amount of care that is needed to take care of diabetes during Ramadan, and hope we could play our part and do some justice to all these patients who are going to fast during the holy month of Ramadan. And thank you, tech team, for being there and giving us all the support that you have given. That's all from us.
Thank you very much.
Thank you very much.
Thank you.
Thank you.
thank you all. Happy Ramadan in advance.
Thank you. Wishing everybody the same. Thank you.
Thank you. Bye.
Good night, everyone.
Good night.